All right, we're here live again today with Dave from NYC Pain MD. And NYC Pain MD is a medical clinic in New York City, and they specialize in treating pain, especially of the knee, the hip, shoulder, back, you name it. And there's some great news. There's some research out, and the research, I'm going to let Dave talk about it, but it's great news for knee arthritis sufferers. This study came out, and it really confirms what these guys have done there to help patients for years now. And I think you guys are going to be surprised. And it shows a great treatment that if you have knee arthritis pain, you should definitely look into. So, Dave, you're here.
Yeah, I'm here. Thanks, Brad.
What about this study you sent me? I just looked it over. You sent it to me, and it's
Right,
pretty incredible stuff.
right. So, of course, knee OA affects a dramatic amount of patients, and it's brutal when you have knee arthritis. You and I have talked about it on a number of webinars. While there's been a lot of good studies, this has just come to my attention. It was actually out, and it was in the the Journal of Knee Surgery, actually. And this article about viscose supplementation or lubricating arthritic knee joints was in a surgical journal, not in a rehab or physiatry or rheumatology, in a surgical journal. It was actually written, it was headed up by a pharmaceutical doctor, but also a doctor who is an orthopedic surgeon. His name is Dr. David Waddell. Now, Dr. Waddell had come up with a very interesting article about 11 years ago, where he talks about how he was seeing a dramatic need for knee replacement and delay back in 2007. It was actually printed and released out of the Journal of American Managed Care, where they're really trying to find ways to apply procedures to save dollars. And the amount of monies that he came up with saving, the amount of knees, is actually staggering. We can come back to that in a minute. I always wanted someone to follow this up to reconfirm, like, of those patients that still didn't have knee replacement after 3 years, which was 82% in 2007, to follow up that cohort or group of patients. Well, his wish was my command, because I finally discovered this in the Journal of Knee Surgery, and he actually put this out in 2016. So it's recent, but not brand new. And basically, the results were pretty staggering. I think, stepping back a minute, it's what we in our group, and I'm not one of the treating physicians, really believe for a long time, that many of these knees can be, not only can you delay knee replacement, Brad, but you can actually completely eliminate the necessity or the patient's desire to have that knee replacement. And I think that's crucial. It's one thing to delay a procedure. It's another thing for patients to do so well that they never end up needing that procedure, which is 10 times the cost, 10 times the risk, and much more of an issue for patients to go through. And so let's talk a little bit about this. So let me do a quick summary. He started this study in the early 2000s. He finished the first one in 2007, and he did a second cohort. But ultimately, he reviewed 1,863 cases of knee arthritis treatment. Now, in order to get those 1,860, let's round it to 2,000 patients. These are patients that did not have light or mild knee arthritis. They had end-stage knee arthritis. They were all approved or cleared for total knee replacement, an artificial knee. At the time, it looks as if the way they did the study, they offered patients the option. Those patients that wanted knee replacement within 90 days had it, but there were many that said they would try the program that Dr. Waddell was offering. Here's what happened. Dr. Waddell put this group that chose the viscose supplementation, which was done under imaging, we'll talk more about that, into the program. And over the next several years, they got between 1 and 7 courses of the lubricants. But the outcomes were amazing. After 11 years, and he gathered all this information, 75% of those patients who went into the non-surgical group with the image-guided viscosupplementation, 7 years, actually 7.3 years after, that's how long they measured it, 75% or 3 out of 4 patients still had not needed to undergo total knee replacement. 25% did, but even those patients were able to delay it roughly 2 to 3 years. But of the 3 or 4 that survived the knee replacement, keep in mind that in a world of cancer, if you survive 5 years, you are considered cured. You are a wonderful stat if you get past 5 years. So actually, Brad, 3 out of 4 patients just ended up not having knee replacement and being able to avoid the risks, and the risks are many, which we can go through, as well as the dramatic cost to both themselves and the system and the time in rehab and all the things that go along with surgery. So this was basically right along the theory that our docs had, which, hey, we not only want to make you feel better and delay any procedures like knee surgery, we want you to be able to totally eliminate it. And I think this is now proof positive. There's several other studies that have come out, a Korean study, a 5-year study, a French study, which only went out 3 years with more than 80% surviving surgery. So this is not the only article proving this, but I think it is a dramatic final exclamation point on that is not only theory that this can help prevent a surgery, but it's actually come to fruition. And this is with a real live group. It's not from a study out of a school or a university. These are actual orthopedic patients that went into this clinic and were able to get these fabulous results. So I think that's a good start. And I know you had a whole bunch of other questions for me in regard to that.
Yeah, because I hear a lot, especially the internet. You see comments and stuff. People say that, that they've heard of viscosupplementation or they've had it themselves and it doesn't work. They've either heard it doesn't work or they've tried it themselves and they say it didn't work for them, and they're actually advising other people not to get it. And now you guys have proof. You guys have done this, of course, but now there's some proof here. What's your take on this? That there's quite a few people out there who don't believe in this or have actually had some pretty bad results themselves. Why could that be?
So I think that a tool is only as good as the person that's using it. If you gave me a paintbrush and said paint the Mona Lisa, it would probably come out like a big mess. That's not to say all the doctors out there are incompetent, but there's a level of skill that has to be applied to the application of these special lubricants. And I would step back and say this, as I know, and you've been in medical writing for a long time, there's no medical procedure on the planet that works 100% of the time. Every case is individual, unique, has its own idiosyncrasies, own problems, own uniqueness. But in our case, roughly 4 out of 5 patients do quite well and are very anywhere from satisfied to absolutely extravagantly, wildly happy about their outcomes, particularly if they don't have to have surgery. So 4 out of 5 is not 5 out of 5. So there's always some patients that don't respond. First of all, those are probably, that may be the patients that are saying, oh, this doesn't work. But this is not a belief system. This is real hardcore medical science. And the fact is that this works. But let me tell you why I think we get the best possible results in our clinic. And it goes right along line with what this article in a Journal of Knee Surgery talked about. One of the things they did, and they point out, and there's very few articles I can remember pointing it out, how important it is to use what's called fluoroscopic imaging. Now, imaging, Brad, as you know, is used to make sure the procedure is pinpoint accurate. When you treat these, what they call grade 4 knees, almost bone to bone or bone to bone, it's really like getting a thread through a needle. And I'm not very good at that. I'm a little nearsighted. So if you go into a very narrow joint and you try to get a very fine needle in between that knee space, exactly where it needs to be, and you try to do it without any guidance, without a guidance system, without a picture, without a moving picture, well, good luck. And the data on that is that you can miss the knee space 30 to 40% of the time. I'm going to imagine that study that said the 30-40% miss rate done by a Dr. Douglas Jackson was not on all stage 4 knees either. So if the knee is a little healthier, it's easier to get in there. I'm going to imagine the miss rate might be as high as 50% if you go in there without imaging. So one of the keys, and it cites it in this article, is that they used imaging for precision and safety. And that's what we do in our office. Every patient that's treated with a knee arthritis procedure goes under fluoroscopic imaging, and we triple confirm the exact application of that medicine. So I think that's a key. If someone's at treatment without the imaging, that could be the whole ball game right there. I mean, if you're having a series of 3 treatments or 4 or 5, whatever it might be, or just one, if you miss the joint space, you know you're going to fail the procedure. And if you fail the procedure, you're going to say, well, this doesn't work, but it wasn't the treatment that didn't work, it was the application of the procedure. So I think that's a key fact to remember when you hear this from other people, as well as the fact that everybody does respond different from the next. I mean, we have knee surgery patients done in the finest hospitals in New York City, and they're in agony and worse and wish they never did the procedure. Not all of them, but you know, the procedure just didn't work for them. And so I think those are issues, but I think the key is the imaging has to be done. You have to scientifically apply that lubricant.
I've also heard that that the viscose supplementation should only be done early on, before the knee's that bad. This study was done, these knees were in stage 4, correct?
Yeah, yes, they were.
What does stage 4 mean?
So when you grade an arthritic knee or joint, particularly the knee, 2 guys called Kellgren and Lawrence came up with this grading system, grade 1 to 4. 1 is very mild, early onset. 2 is a little bit more significant, more wear and tear, more narrowing of the joint. 3 is starting to advance, and grade 4 is essentially what patients might call bone to bone, with a lot of roughening of the joint surface, sometimes bone spurring, significant narrowing of the joint, sometimes where one aspect of the joint will be narrowed, so you might get bow-legged or knock-kneed. And so obviously this study proves that patients that have even this, what's sometimes called end-stage arthritis, can get significant help and even avoid the typically where patients feel they're destined for replacement, they're actually being able to avoid it now.
These are the worst of the worst, pretty much. And the study showed 75% of them, after 7 years, didn't have to get the knee replacement. And that's that, you know, and in this, you know, scientific world, medical world, that's incredible results. But what else would you like to say about anyone out there who's suffering and would like some more information about this?
Well, just one little add-on, and then I'll answer that question. In the previous study by the same doctor, which went from 97 to 03, you have to understand this. They reported that only 1 out of 5 patients ended up in knee replacement with only 1 course of the lubricant. 1 course, image-guided viscose supplementation. And after 4 years, 77% of the patients still didn't need to have the surgery. And this is very important. The only important in this was age, and that the older patients seem to end up in the surgery more than the younger patients, perhaps a less ability to heal. But you're talking about, 4 out of 5 cohort kind of confirmed all that. So I would say that no matter how bad, to answer your question more specifically, no matter how bad your knees are feeling, no matter what anyone tells you, and there's some of the most fabulous orthopedic surgeons in the world in New York City, or maybe the city of where you're listening to this. They do fantastic work. However, I want to let you know, you do have options, and that even if a doctor tells you, oh, you're bone to bone, you need surgery, well, they haven't been keeping up with the research, because this research clearly points out that even those that have been earmarked and quote unquote destined for surgery are getting pretty good results without having to go under the knife and have an artificial knee put in and go through all the stress, expense, time, and risk to their own health. So what I would say to those patients is, before you take the leap, get an evaluation, get a screening with a clinic that does procedures like ours, wherever you might live. We do, of course, and you'll put up a number. They can call for a free screening to see if we might be able to help them. But explore this first before you let because once that knee replacement is in, you can't go back. Explore this first, see if you're a candidate, and it might be reasonable to try, and give that an opportunity first. Knee replacement is not simple. It's not like snapping two Lego toys together. It's a major, major surgery. And while some patients need it and it's the best option, many of you could probably do quite well with these other options that we're talking about right now.
NYC Pain MD has some incredible doctors there. You guys have some doctors that were trained at Harvard, correct?
Mm-hmm. Yep. Yes, he's excellent and very nice. Most important, really a nice guy with not only good skills and brain, but just a good guy who really cares about patients and does a really good job guiding patients. So, education is very important, but also being able to relate to patients, make them comfortable, get them understanding things, and, steering them in the right direction. Clearly, Brad, there's besides grade 4, their knee may be so shifted or bent in the wrong direction that they don't feel the viscosupplementation would be helpful, and they'll tell them to get the knee replacement. A small percentage of cases, so we can't help everybody, but you also want to say, yeah, I think it makes sense to try it, or no, I don't think there's any way you respond. I think you want to make sure that when you come in, you're not only someone knowledgeable that's going to give you a clear-cut, straight-laced answer, and make sure that when you walk in the door, you're comfortable. When you walk out the door, you feel like you have very significant guidance, and you'll know what to do, and you'll have a plan.
Some great stuff. It's just great that that there's there is. Are you there?
Right. Yeah, I'm here. Mm-hmm.
Yeah,
you got a little disconnect for a moment.
Yeah, we're having a little problem with the connection here, so we're gonna end this call soon. But it's just great now that you've been telling me about these results for years, and it's great that there's hardcore some research now to show it, and there's some absolute proof here, and it's really great for people to know. And you guys are going to be able to help a lot more people now, because when there's that proof out there, it just really helps. So anybody out there that has knee arthritis pain, give these guys a call. It's great. Anything else you would like to end this with?
Yeah, well, when you talk about why people should be evaluated for this or consider it is, one of the things in this article is it points out that the complications of knee replacement have been really extensively studied. And so here's just a brief list of what the possible risks include. There's a risk of infection, a risk of embolism or blood clots from the surgery. In fact, 1 in 400 don't make it past 30 days after. Likely from an embolism, and why it's a very small percentage, it's a risk. There's bleeding issues, there's nerve damage that's a possibility, vascular injuries, urinary complications, and overall increased mortality. So these are things that you have to think about. Surgery is not a simple thing, and I think the votes are in, the results are in, and this basically finalizes what, again, you and I have been talking about for years, what we've kind of believed, but we don't like to go out on a limb and say things unless a formal study is done. And I think this kind of, really nails the case closed, so to speak, along with all the other stuff that's out here. And anybody who wants a copy of this article or a little packet on just research, we have them. We have packets on the basics of what we do, as well as many other procedures like nerve blocks and shoulders and hips and so forth. But I think this should really move the science of viscosupplementation forward and get people really confident that this is something they should think about checking out for themselves.
Yeah, we're gonna put up on the website, and I'm gonna put the website address up on the screen here, so you guys can check it out. You guys can go there, and you can read about the doctors. You can read about the procedures. You can request information kit. You can see the research here, and you can make an informed decision. So the website's up on the screen here. Give these guys a call. The number's up on the screen. If you want a free screening, they'll check you out. We're going to end the call today. And thanks a lot again, Dave. Every time you're on, the feedback we get is great. Everybody emails me saying how it helped. And a lot of people email me saying because of these, they went in to see you guys and they're out of pain now. So great stuff. And
Right.
we're probably going to talk again in about a week. So I'll see you then.
You got it. Okay. Very good. Thanks, Brad.